Alright everybody, we've talked about the heart, now it's time to move on to the lungs and largely the respiratory system. So we've seen a lot of the head and neck structures already, but now we're going to be reviewing those briefly in the context of how air travels through them to get into the thorax and the lungs. So let's talk about the respiratory tract in its most general way. Essentially we have to have a lumen full of air, and lining it needs to be an epithelium. Now, the nature of that epithelium and the type of cells surrounding it will change depending on how high or low we are in the airway, but generally there's always going to be an epithelium there. Surrounding it is something called the lamina propria. This is an area full of loose connective tissue and small vessels that supports the epithelium, and outside of it is a muscularis layer. That's a very thin layer of smooth muscle. Outside of that we have a much more stout band of connective tissue called the submucosa, and that's where the bigger vessels are going to be hanging out. And outside of that we have the cartilage, which is sometimes described as being in the submucosa, sometimes a separate layer. Generally you can think of it as submucosa, but it only is present at a few levels of the airway. And last we have the adventitia, or the connective tissue layer that anchors the airway in place. Now we don't have that at every level, but we do have it at some. So let's talk about the epithelium. Basically, most of the respiratory tract is covered by what's known as respiratory epithelium, and it consists of very tall columnar cells called pseudostratified ciliated columnar epithelium. Let's break that down. Pseudostratified, meaning, if you look at this on the left, it looks like there's layers of cells, but in fact all of these cells are anchored at the basement membrane down here, stretching up with their cilia sticking out into the lumen. So they're pseudo-stratified. They look stratified, but they're not. They're actually columnar. Cilia sticking off them makes them ciliated, and they are sitting alongside several cells, these kind of vacuous spaces right here, and shown here by these darker spaces called goblet cells. Goblet cells release mucus, and they release a lot of it. So the mucus in your airway is coming from these goblet cells, and it's actually a pretty important structure in the airway. So let's talk about the airway itself. We have a conducting area and a respiratory area. And respiratory basically means that gas exchange is happening there. So starting at the nasal cavity, we breathe in, we pass through the nasal cavity, the nasopharynx, down the oropharynx, we divert into the larynx, down the trachea, split into the right or left bronchi. Then we're going to go into several divisions of bronchi, many divisions of bronchioles, until we finally get to the point where there's a bronchiole, or a small bronchus, with alveoli, little gas exchange cells sticking off of it. Now I said cell, I didn't mean actually cell, I meant like a small compartment or a small space. So those alveoli are small spaces, and as we go further and further down, we run into alveolar ducts, which are going to be hallways lined by alveoli, alveolar sacs, little squat areas like filled up a bunch of grapes with the alveoli sticking off like the grapes. An alveolar sac would be like a little bundle of those. And then the alveolus, the smallest level of the respiratory pathway, will be those little tiny spaces where gas gets to and interacts with blood vessels in the wall of the alveolus, where actual gas exchange will happen. So that's the quick review on where we're going. Let's get started with the nasal cavity. Now, in addition to transporting gas from the outside into the depths of our lungs for gas exchange to happen, the nasal cavity is also the start of a process that happens all the way from top to bottom, which is the exclusion of nasty stuff from the airway as well. We don't want to breathe in and wind up with lots of particulate matter, pollution, and nasty stuff going deep into our lungs. So we have a few mechanisms to catch that particulate matter, or even larger things like bugs, hairs, other things like that as we go. So our nose, the vestibule of our nose, is lined by vibrissae, or hairs. And in this sense, those nose hairs, although kind of aesthetically unpleasant, are pretty important because they're blocking things. If you've ever had a bug attempt to fly up your nose, you should be very thankful for those hairs because they stopped it getting too far in. So that stratified squamous epithelium of the nasal cavity very quickly transitions to the respiratory epithelium back here, which will be that pseudostratified ciliated columnar epithelium. Remember the conchae or the turbinates from head and neck? Now those are present. A lot of times they're described as creating resonance when we speak or warming up cold air, and they do that, but I think they also literally create turbulence, hence the name turbinates, and that turbulence slams air into your mucous membranes, which we have lots of goblet cells releasing mucus, so particulate matter, pollution, other things that we might breathe in get stuck in that mucus before they have a chance to get down deep into your lungs and cause problems. So it's nice to have those so that bacteria, viruses, and other nasty stuff don't get too deep before we go. Now the lamina propria in the nasal cavity has lots of distended veins called swell bodies, as well as glands that are releasing some mucus as well. So right here is a big extended and distended vein, and if you've had respiratory congestion before, which I know you have, these veins swell up, swell full of blood, and create that congestion, narrowing of the the airspace within the nasal cavity. We have multiple glands nearby as well, releasing their products alongside the goblet cells that are right here within the respiratory epithelium right there. Now we move from the nasal cavity to the nasopharynx, down the oropharynx, and then as we breathe, the air gets diverted into our larynx and away from our laryngopharynx, where we'll eventually get our esophagus. So the larynx, right here, we have the epiglottis, just posterior to the tongue. As we look down, if you remember from head and neck when we talked about cranial nerve 10, we're going to see a false vocal fold first, a true vocal fold second. The space between the two is the ventricle, and the little gap between the two true vocal folds, that's called the rima glottis. That's the actual opening of our airway. And that also tends to be the narrowest point and the point where things tend to lodge when we suffocate. If we look at this from the side, we can see the cartilage here of the thyroid cartilage, cricoid cartilage here, true vocal fold, lower than the false vocal fold, packed full of muscle. Remember all those muscles that cranial nerve 10 innervates? They're all packed in here. Then very little muscle in the false vocal fold, mostly just a little bit of fat, connective tissue, and glands. Now as we look at it, something interesting happens here. Our airway is mostly lined with respiratory epithelium, pseudostratified ciliated columnar epithelium. But those cilia, those little structures on the surface that beat the mucus along so that we can either spit it out or swallow it, are not present on our vocal folds. Those cilia are really delicate, and they're not going to deal with being slammed together like we see here with our vocal folds. So the vocal cords are capped by non-keratinized stratified squamous epithelium. We can see it right here. And our body puts that type of epithelium, those layered flat cells, in places where a lot of abrasion, friction, or just outright trauma is happening. So as we speak, our vocal cords are just slamming together over and over and over. So having stratified squamous epithelium there is a good thing. Now, if we have someone who's coughing very violently over and over and over, they can wind up replacing the ciliated columnar epithelium of that area with the stratified squamous epithelium, and that's bad news. You don't want this epithelium growing places where it's not being put to use. So moving from the larynx into the trachea, the big thing to notice about the trachea is it has a C-shaped cartilage ring supporting it at various levels. So we have lots of these little C-shaped cartilages with a fibroelastic membrane behind it. And the reason we don't have a complete ring is that the esophagus is sitting just there. Now, we haven't talked about the GI system much, but I don't think you have to imagine what would happen if we had a solid ring of cartilage here, then we swallowed a big chunk of food. It would compress and possibly break that cartilage. So instead, we have a nice little membrane here, and as food moves down the esophagus, it might push that membrane into the trachea a little bit, but not enough to occlude our airway for very long. So that's why we've got this C-shaped cartilage rather than a full ring, and that's in the submucosa. The respiratory epithelium and lamina propria are typical, covered by respiratory epithelium, which once again, ciliated, pseudostratified columnar epithelium, right there. Now here's a nice little view of the cilia and goblet cells. Goblet cells, once again, release mucus, which the cilia beat towards the oral pharynx, so we can either swallow it or spit it out. And it's nice that we have that. Although if you've had overproduction of mucus and been hawking it up for a while, it doesn't seem like a blessing, but it's nice to have it there so that we know bacteria and viruses are not getting a shot at our lower airway as easily as they could if we didn't have that layer of mucus there and cilia moving it along. So, traveling down the trachea, we then split into right and left bronchus. Now, the right and left bronchi look a little bit different. They're also called the primary bronchi because they're the first ones that come off. The right primary bronchus is going to give off 3 secondary bronchi. So right here we have a secondary bronchus going out to each lobe of the right lung, a superior, a middle, and an inferior. Whereas on the left we have a superior and inferior lobe right there. So primary bronchi give rise to secondary, and as you can see, we have tertiary bronchi sticking off of there. Now, there are other divisions of bronchi, but we're going to leave it at first, second, and third because something interesting happens there. First off, let me back up just a tiny bit. Instead of cartilage rings, which we lose as we move from primary to secondary bronchi, we just have cartilage plates in the lumen. Now, at this point, we're not worried about the esophagus, but we still have cartilage there to hold the airway open. One thing you might discuss in physiology is that as you narrow a lumen, the flow of fluid or gas through it speeds up. And as that speeds up, it's going to tend to compress and have the lumen collapse on itself. So these cartilage rings prevent collapse of the lumen of the airway as we breathe. As we go lower down and lose the cartilage, the surrounding connective tissue, elastic and reticular fibers, actually tends to keep the airways open instead. So as we move into the lung, the lobes, and then the bronchopulmonary segments, we're moving from first to second to third bronchi. So we have a single primary bronchus to the right lung. We have 3 secondary bronchi going to the superior lobe, 1, the middle lobe, 2, and the inferior lobe, 3. And we have those subdivide into 10 tertiary bronchi. Now, quick aside, I'm not going to ask you guys to identify any tertiary bronchi, but I do want you to be familiar with the concept. Basically, these tertiary bronchi don't leave surface impressions. We have a single superior lobe, and it's there, separated from the middle lobe by this horizontal fissure, and they're each separated from the inferior lobe by this oblique fissure. However, inside the lung are connective tissue divisions between these segments, so they are actually physiologically distinct, and I can have infection and consolidation of one that does not affect its neighbors because there's a connective tissue wall within the lung between them. So just for the sake of completeness, superior lobe of the right lung has an apical right here, posterior and anterior segment, and there's a tertiary bronchus going to each of those. Right here, the middle lobe has a medial, medial and lateral segment. You can see it on this side as well. And then the inferior lobe has some interesting stuff going on. It has a superior segment, but remember, it's the superior segment of the inferior lobe. So it's actually pretty far down here. And then all the others have the words basal on them because they're in contact with the diaphragm. So here's the anterior basal, lateral basal, posterior basal, and medial basal. So they're all in contact with the diaphragm, and we can get pneumonia as segmental pneumonia in any one of those. Same drill for the left lung. We have a single primary bronchus going to the left lung as a whole, and then it divides into 2 secondary bronchi, one to the superior lobe and one to the inferior lobe. Now, there are different versions and different textbook sources. Like I said, I'm not going to ask you segmental questions, so this is one version. There's likely some variation between individuals at the root of it. So here, an apical right there, and then posterior tends to be fused. So it's often called an apico-posterior lobe in the left lung, then an anterior. Then there's no middle lobe, so we just roll right down into these other segments that are connected to the superior lobe, the superior lingual and the inferior lingual. And it's called lingual because this portion of the superior lobe in the left lung someone thought looked like a tongue. So there you go. There's the lingual segments of the left lung. Now, down here in the inferior lobe, things are pretty much the same, except frequently the anterior and medial basal segments are fused. So we'll have a superior segment of the inferior lobe, a posterior basal, a lateral basal, and an anteromedial basal, or sometimes divided into an anterior and medial basal. All right, if you got that, we're good. The payoff is you should know that different diseases and different tumors can actually result in clinically different findings based on this. You can have pneumonia of a single segment, so you can have a segmental pneumonia, or you might have to remove a lung tumor, but you might be lucky enough to get it before it spreads widely and only take out a segment, do a segmentectomy. If it's spread further, or you have lobar pneumonia, well, generally with pneumonia you don't take a lung out, but just be aware, lobar pneumonia affects an entire lobe, in this case the superior lobe of the left lung. You can also do a lobectomy if you need to remove that entire lobe, and if things get really bad, you might have to take out an entire lung along with its primary bronchus. In this case, we've got a full pneumonectomy on the right side. Now, quick quizzical question for you. We can have pneumonia or consolidation, fluid, blocking an entire segment or an entire lobe, or maybe, if we're really unlucky, an entire lung. And yet the tissue in that lung, the airway itself, stays alive. So it's not relying on the airway itself for its own oxygen. It's not relying on the pulmonary arteries at many levels for its own oxygen. The lung tissue can stay alive because the airway has its own blood supply coming off the thoracic aorta. These are called bronchial arteries. So they're leaving the aorta, they jump onto the secondary bronchi, or sometimes primary bronchus, and travel down and split. And they travel a long way down the airway, and they are what supplies blood to the actual airway itself. Bronchial veins are going to drain into the azygous system of veins, which is a large cluster of veins that we talked about, I believe. Yeah, we talked about it in the first lecture. So just remember, we've got the azygous on the right, hemiazygous and accessory hemiazygous on the left, and the bronchial veins will tend to drain into that system to get out. Here's a quick view of that. Bronchial veins on the right to the azygous, on the left to the hemiazygous or accessory hemiazygous. Now, if we go down the airway to a fairly significant degree, what we're going to wind up seeing is here a respiratory bronchiole, little bronchus with an alveolus sticking off of it. Further down here we get to the alveolar ducts, the alveolar sacs, and then the individual alveoli are just these little blebs right here and here and here. So we have the airway bringing oxygen in, down, down, down. We have the pulmonary artery bringing deoxygenated blood to the alveoli. Alongside, we've got bronchial arteries, these guys, red because they're oxygenated, supplying blood to the airway as well. So the pulmonary artery brings its blood into the area, right there. It's going to spread out and form a network in the wall of the alveolus. That network is where thin-walled vessels meet thin-walled airway, gas exchange occurs, and then the CO2 gets put into the airway and exhaled, and the oxygen-rich blood consolidates into bigger and bigger pulmonary veins, which will eventually wind up at our left atrium. So once again, the bronchial artery runs alongside, and at these very small levels, it might just wind up going into the alveoli and going through the pulmonary vein as well. The alveoli are the little sacs where gas exchange happens. So let's talk a little bit about the airway itself. Now, bronchi have cartilage in their walls. They give way to bronchioles, which have no cartilage, but they're opened by the connective tissue that they're anchored to within the lung tissue. There's no cartilage there, there's no glands present there, and instead of ciliated columnar epithelium, we wind up with squat little cuboid ciliated cells alongside some dome-shaped what are called bronchiolar exocrine cells. Now I'm going to go on a brief tangent here, so just bear with me. History of medicine is one of my little hobbies, so this is one that's actually important. You will always hear these bronchiolar exocrine cells, also sometimes called club cells because things have to be difficult, but you'll hear them referred to as Clara cells, named for the guy who discovered them, Max Clara. Now, first off, anatomists are trying to get away from eponyms because naming something after a person doesn't really tell you much about it functionally. But in this case, we also don't want to call them Clara cells, despite the fact you're going to hear them called that, because Max Clara was a huge Nazi who experimented on concentration camp victims and did most of his experiments on tissues derived from people who were executed by the Third Reich. So, of all the people we could choose to maintain their name in conjunction with something, let's not pick him. There's plenty of other people who we could more justifiably maintain eponyms with. All right, that's my aside over. What these bronchial or exocrine cells are doing is releasing ions into the airway. We don't want our airway to get completely dried out. So these ions do what ions do. They pull water into the area, and they also release glycosaminoglycans that are going to help lubricate this area and will eventually give way to what's called surfactant. So, after we leave bronchi, we enter the respiratory part of the respiratory system. Now, just in case this comes and bites you in the rear eventually, the terminal part of this respiratory pathway is called terminal bronchioles, and yet terminal bronchioles are not the end of the airway. I hate this terminology, but I'm stuck with it too. They're just the end of the conducting portion. After terminal bronchioles, we enter respiratory bronchioles, which are exactly the same except they have little alveoli occasionally blebbing off their surface and allowing gas exchange to happen. We move further down from these respiratory bronchioles and we enter what's called an alveolar duct, a pathway lined by alveoli pretty much completely. The alveolar sacs, these little bulges, large-scale bulges sticking off the side. Then the alveoli specifically are the individual little bumps right here. All right, I think we've hit that a couple times, so hopefully we've got it. Let's take a look at a histologic specimen. One thing I haven't drawn much attention to until now, but I'm going to make up for it, is the fact that there's smooth muscle all the way down your respiratory pathway. So from our larynx down to the alveolar ducts, we have smooth muscle in the wall of the lumen. Now that's good because we want our airway to be responsive and allow itself to open up or close depending on the circumstances. If we're running and we really need a lot of gas exchange, we want that smooth muscle to relax and open up the airway super wide. However, if we're just sitting peacefully and breathing, we don't want a wide open airway because we don't want bacteria and viruses having a clean shot down a wide open lumen to the depths of our lungs. So our airways tend to constrict, and that's what the smooth muscle is doing when we're relaxed. So typically, that's a good thing. As we'll get to in a minute, it can become a bad thing if you have spasm of that smooth muscle that inappropriately locks down your airway. But more on asthma in just a second. So here is an alveolar duct. It's a hallway lined by alveoli, and it's the last part of this system that has smooth muscle in its wall. So we go a little further, and now we see actual alveoli. These little, I want to call them cells because they're little cells of space, but they're lined by actual biologic cells, so I'll try to stay away from that terminology. So these terminal air spaces, and they're lined by cells called pneumocytes. They're separated from each other by interalveolar septa. So this wall right here, that's an interalveolar septa, and I think you can see without too much imagination, it's really thin wall there. And within that thin wall are blood vessels. So this is where the capillaries for the airway are winding up. Here's a slightly larger vessel right here. You can see the blood cells in it right there. So even though our lungs are relatively small organs, they're medium-sized or large, the surface area in them is massive. Basically 1 tennis court's worth of surface area in each lung. So let's talk pneumocytes, because there's two kinds. The first kind are called type 1 pneumocytes, and they're incredibly flat. They're the cells that allow gas exchange to happen. So, gas is in the airway. Gas can pass through the type 1 pneumocytes, these little flat dudes, to get to the blood vessels, the capillaries that are in the interalveolar septum. So, I happen to love this little thing because it drives me nuts. These cells are the minority of cells in the lung, yet they take up 95% of the space. So picture some jerk sitting on the bus or the subway on a seat, but his legs are sprawled out, his arms are spread out, and he's taking up basically 3 or 4 seats worth of space. That's a type 1 pneumocyte. So it's spreading out, and even though it's the minority, it's taking up all the space it possibly can. Next up we have type 2 pneumocytes. Now they make up 60% 8% of the population, but they're squat. They're smaller cells. Well, they're kind of rounded, pardon me. They take up less space. They're not smaller, but they're rounded. These cells are the stem cell population for type 1 pneumocytes, and they can also divide to create more type 2 pneumocytes. But in addition to being stem cells, in addition to creating new type 1s, they are also the cells that release surfactant. And surfactant is crazily important in lung function. Basically, if your lungs did not have something along their airway surface to smooth out the resistances that it encounters and to push smaller spaces away from each other, we'd wind up with our lungs collapsing all the time. So if you have surfactant, your lungs are able to expand relatively uniformly, and without surfactant, they want to collapse. So these type 2 pneumocytes are a huge deal, and so is surfactant. We'll talk about why when we get to development of the lungs in a little bit. Last, let's talk about the interalveolar septae, the actual spaces between adjacent alveoli. And here we can actually see the red blood cells inside the walls, traveling through, giving off CO2 into the airway, picking up oxygen from the airway, and moving into the pulmonary veins. So this blood gas barrier, this little division between the capillary and the airway, is thin as we can possibly make it. Basically 0.2 microns in thickness. And yet there's 3 layers there. There's a type 1 pneumocyte in the airway, there's a fused basal lamina, and then a capillary endothelial flat cell in the actual vascular space. Here's an electron micrograph. Here's a type 2 pneumocyte, big chunky guy. Here are red blood cells, erythrocytes, and right here, this little kind of mottled strip here, that's a type 1 pneumocyte, pardon me, that's endothelial cell. That's lining the blood vessel. The little slightly clearer area, that's the fused basal lamina. And out here, here's the, as thin as it can possibly get, type 1 pneumocyte cytoplasm. And gas exchange can occur across this boundary with some help from the cells. Alright, so that's basically the lung's parenchyma. But there are some helper cells in the area. Despite the mucus, despite the turbinates, despite the smooth muscle narrowing the airway, we still get some tiny bits of particulate matter, bacteria, other stuff, some carbon bits down into the lungs, and we don't want it there. So we have alveolar macrophages, in this case called dust cells, and they are there to phagocytose foreign material and move it up the airway until we can either spit them out with the mucus or swallow them with the mucus. And I'm sorry for putting that image in your head, but we all do it. You just have to deal with it. These macrophages are moving into the airway, and it's called the mucociliary escalator, as they are swept up by the cilia along with the rest of the mucus. Now, these cells are normally present but not excessive. But if we have a great deal of intake of particulate matter or congestive heart failure causing fluid to leak into the airways, we can have an abnormally large number of these macrophages coming in to try their best to phagocytose whatever's there and get it out of the way so that we can have efficient gas exchange occurring. And here's a picture of congestive heart failure in the alveoli. You can see all this fluid, all this gunk in here, and almost all of these cells here, these are all alveolar macrophages doing their best to bail us out. They're all have a bucket, they're trying to move that fluid out, but as congestive heart failure worsens, they may not be able to keep up with the flow. So what can go wrong? Well, lots of things. First off, if the smooth muscle lining the airways is not behaving appropriately, it can constrict due to irritation or overuse, or even just due to environmental insults, but this can result in asthma when we have spasm of that smooth muscle in the airways, narrowing the lumen, making breathing very difficult. So this tends to be associated with excessive mucus in the bronchways, inflammatory cell infiltration, and it often is just going to be something that is induced by exercise. So treatments with things that are going to activate the sympathetic nervous system and cause that smooth muscle to relax, bronchial or smooth muscle relaxants, are going to be a big part of being able to deal with asthma, although the specific treatments will depend on the exact mechanism by which that asthma is occurring. Now, another big problem that can come up is cystic fibrosis. in this case, we don't have a functional pump for chloride in the cells that's going to pump chloride out into the airway. Now that chloride, in and of itself, isn't our major concern. What we care about is the fact that if we don't have chloride in here, we're not pulling water out here, and the mucus in the airway gets excessively sticky and excessively kind of basically gunky, and it will stay in place. It's hard for the ciliated cells to move it along, and so we're going to wind up with mucus that's stuck there, serves as a bed for infection, makes breathing difficult, and basically when we have a mutation in that chloride pump, the CFTR channel, we're going to wind up with cystic fibrosis, and it makes breathing very difficult and makes it likely that you're going to wind up with infections that eventually either cause, sepsis or just make it difficult for the person to breathe and asphyxiate them. This tends to be treated with symptomatically, but can actually be dealt with more or less permanently through a lung transplant. Now, emphysema is a condition that happens when the walls of the bronchi break down and are replaced by air. So instead of having lots of little alveoli with lots of surface area in an area, we have an equivalent area with one big sac and a lot less surface area on it. So less surface area equals less gas exchange, less efficient gas exchange, working harder to breathe. Now, emphysema tends to happen for two major reasons. One is a deficiency in a gene a gene that results in the enzyme alpha-1 antitrypsin. Now, alpha-1 antitrypsin helps repair and maintain the alveolar walls. So as they get irritated or damaged by inflammation, macrophages, things like that, alpha-1 antitrypsin keeps them intact so that they stay present, dividing adjacent alveoli. If you have a deficiency in that gene, they'll start to die off. And here, instead of multiple little alveoli, we'll have a single sac taking up that space. And as the walls between it and its neighboring sacs erode, they fuse to form an even bigger sac with much less surface area than we had in an equivalent space down here. Now, smoking can inactivate alpha-1 antitrypsin, and that can cause a similar type of damage, but it tends to affect a little bit higher up here in the respiratory portion of the airway. It tends to happen up here in the respiratory bronchioles, maybe alveolar ducts to a bit, whereas down in the rest of the alveoli, this pan-acinar emphysema is more associated with the alpha-1 antitrypsin deficiency. Another cause of lung disease that's sometimes underappreciated is silicosis. Inhalation of fine particulate matter, particularly sandy or glass-type matter, can cause massive irritation of the airways. So silicosis is caused by fine particle inhalation, and when these particles lodge deep in the lungs, our macrophages try to get rid of them, but they can't. And that sets up a massive cascade of inflammatory factors, inflammatory reactions, and goes by the name of pneumoconiosis. And it basically is a very gradual and somewhat irreversible inflammatory problem. So people have to wear respiration anytime they're working with fine silica dust. Now right here we have, I'll take the suspense out right away, an article from The Onion. So sadly, I can't pretend, I don't want to string you along, but glitter lung, aka pneumosparkliosis, is not a real thing. But I salute the people at The Onion for coming up with this incredibly clever respiratory disease. So go ahead and pause, read along as you wish, and then enjoy the fact that they even thought to give us a CT scan to go along with it. So there we go. Question time. Go ahead and pause, see what you think. And these domed non-ciliated cells are the bronchiolar exocrine cells. A. Next question. Pause. Alright, the most distal portion of the respiratory tract contains smooth muscle are the alveolar ducts, also A. So let's back up now and actually look at the surface of the lungs and how these organs interact with their neighbors. So right here is the right lung. Superior lobe, middle lobe, inferior lobe. Inferior lobe is separated from the other two by a long oblique fissure, whereas the superior and middle lobe are separated by this horizontal fissure right here. And I should mention, I've occasionally seen some incomplete horizontal fissures in my time, so they're not always as textbook as you might like. Left lung is easy. Apex is up here, base is down here. We have a single oblique fissure separating the inferior and superior lobes, And there's a cardiac notch present here near the lingual region of the left lung's superior lobe, where it's kind of hanging over the apex of the heart. So right here, we've got a picture of the mediastinum, that central area of the thorax, and we've removed the right lung. And just for fun, there it is. So let's look at its relationships. There are pulmonary arteries, and I think they should be blue. I like blue for oxygenation status, not for veins exclusively. But there they are. They're fairly superior in the hilum there. Then we've got the pulmonary veins, a little bit more inferior and anterior. And right there, nice big impression right there for the heart. So the right atrium, maybe a little bit of the right ventricle, right there, making that cardiac impression. The diaphragm is poking upward, and so we have a diaphragmatic surface right there. And nearby, we have the esophagus and the vertebral bodies making an impression on the lung as well. Now, these impressions are not something you need to worry about seeing all the time in a patient, but you should know that they imply that these structures are next to each other and that you can have spread of infection and tumor from one to the other. And no surprise, we've got our bronchi here and here heading off into the distinctive segments of the lung. Let's do the same thing for the left side. Now here is the left lung. Here's the left view of the mediastinum. A lot of the same stuff. There's our primary and secondary bronchi splitting from each other. Pulmonary arteries a little more superior, pulmonary veins a little more inferior. And right here we have the cardiac impression of the heart. So the apex of the heart is hanging out right here, which is why we've got a bigger cardiac notch on the left side. Diaphragm present right there, no surprise. But here, instead of the esophagus, we've got a nice big impression of the aorta, pretty much obscuring the vertebra as well. So no vertebral impression on the left lung. The lungs, let me back up a tiny bit, are lined by something called visceral pleura. It's their outermost layer. And here we can see that the illustrator is showing that there's a sheet of tissue lining this cavity that's been partially reflected right here. This is called the parietal pleura. Now, pleura just refers to the coverings of the lung. Parietal pleura is on the body wall, the diaphragm, the mediastinum. Visceral pleura is on the lung itself. So here we can see that there is a tiny space. It's colored orange in this illustration between the lung and the parietal pleura, or more accurately, the visceral pleura of the lung, purple, and the parietal pleura outside of it. And that fluid in that space keeps the lung stuck to the body wall. And as the body wall expands and the diaphragm drops, the lung gets pulled along with it. And it gets expanded as the diaphragm drops and the ribs swing out. And then the lung contracts as the diaphragm domes back up and the ribs move down. Now, if we have any sort of a problem where the body wall gets disrupted, or we have rupture of an alveolus into that space, this pleural space should normally be full of nothing but a little bit of fluid. But if we have disruption of it, air can rush into this space and collapse the lung. This is called a pneumothorax. Or if I have a little bleb on my lung rupture, it will form some space inside the lungs. That's also a pneumothorax. They can happen traumatically, or they can happen spontaneously. If you have bleeding into the pleural space, that's going to be a hemothorax. And if you have fluid like lymph filling it up, that's going to be called a chylothorax. So let's take a look here. Now right here, you can see that the lung, although it's fairly see-through, it's relatively radiolucent, it still casts a little bit of a shadow. And look around the rim here, we can see there's a much darker rim around it. That darker rim is air that's partially collapsed this lung on this side. Here's a CT of something similar. Now the lung, fairly radiolucent, not super bright, but compare that to actual space with no tissue in it. Right there, that is a collapsed lung, and here's all that lung tissue collapsed at its hilum. Hemothorax, due to a fracture, can compress the lung, and notice it tends to shift the trachea away from the lesion side. As that fills with blood or air, it pushes everything towards the unaffected side, which can compress the only functioning lung even worse. And this delicious picture right here is a chylothorax. That is chyle, or lymph from the gut tube, probably from a ruptured thoracic duct, entering the pleural space. So the pleurae are named for the surfaces on which they're found. So essentially, we have the parietal pleura is the whole thing covering the outside, and the visceral pleura covers the lung itself. But we can subdivide the parietal pleura into cervical pleura, poking up here at rib 1 and above, mediastinal pleura, covering the mediastinum, diaphragmatic pleura, covering the diaphragm, and costal pleura, covering the ribs. Note they're all continuous. They're even continuous to the visceral pleura at the hilum. They just reflect onto the lung right there. But we name them differently because the pleurae in different areas have slightly different functions. One thing about them is to note that the lungs fill up a lot of the thoracic space, in the pleural space, but the pleural lining has to fill up a little bit more. The lungs can't be any bigger than the space that they're allowed to be in. And because of that, the inferior border of the lungs and the inferior border of the pleura are actually separated a bit. The lungs can't fill all the space. There has to be a little bit left. So posteriorly, the lungs tend to extend down to about the level of the 10th rib. As we go more laterally, the 8th rib, and anteriorly about the 6th costal cartilage. We go down to the pleural reflection. That's going to be the 12th rib posteriorly, 10th rib laterally, and the 8th costal cartilage anteriorly. One thing I like about this is it tends to jump by twos. Pleural reflection, rib 12, inferior border of the lungs, rib 10. Laterally, 10th rib, 8th rib. Anteriorly, 8th costal cartilage, 6th costal cartilage. So there's a space between the lung and the place where the pleura reflects back onto the diaphragm from the ribs, etc. And that space is called the costodiaphragmatic recess. And why we care about it is that it's going to be a place we can draw fluid from if there's fluid in that space. Now, I'd like you also to note that the apex of the lung, covered by its cervical pleura, extends up into the neck and can actually be traumatized by neck lacerations and things like that. So as if the carotid arteries, the jugular veins, the phrenic nerve, the vagus nerve, if all of that wasn't enough to worry about, we also can have a collapsed lung due to trauma in this area as well. So if we need to conduct a thoracocentesis, we need to pull fluid, ideally we don't want to put the needle someplace where we're going to stick it into the lung parenchyma, or the lung structure itself. So we're going to try to get it right in that costodiaphragmatic recess. So we're going to try to find the space between the 10th and 12th rib posteriorly, or the 8th and 10th rib laterally, or the 6th and 8th costal cartilage anteriorly. And I'll let you off the hook quickly by telling you, we try not to do this anteriorly because the heart's there. Because we're not wanting to stick a needle in the heart and give them a cardiac tamponade. Posteriorly, we'd have to go through all the erector spinae and other big muscles of the back before we even get to the ribs and then into the space. So most of these thoracocentesis procedures are going to be done laterally. So you find the 10th rib and the 8th rib, and you glide the needle superior to or through the middle of an intercostal space, and that's where you try to draw fluid from that area around the lung to see if it's infectious, if there's lymph in there, if there's blood in there, and maybe even pull some fluid out to allow the lung to expand a tiny bit. All right, last but not least, we have a lot of lymphatic drainage from the lung and multiple lymph nodes scattered throughout the lung and the airway that are pulling that lymph back into circulation into the subclavian veins on the left and on the right. They're named for their position, and the reason we care about them is that this is a major route for spread of lung tumors, and lung tumors happen with a fairly decent regularity. So we want to know how to stage these tumors and be aware of the overall lymphatic flow through this structure. So in the lungs, we have pulmonary nodes. They're scattered in the lung tissue, pulling lymphatic fluid from all levels of it. At the hilum, we have bronchopulmonary nodes, also known as hilar nodes. So pulmonary nodes drain to bronchopulmonary nodes. Bronchopulmonary nodes drain to superior or inferior tracheal bronchial nodes. So these nodes are collecting the lymph that are coming from an entire lung and sending it up the chain. You should know that this lowest cartilage, as the trachea splits to become a left and right primary bronchus, is called the carina, and these nodes are sometimes called carinal nodes. Now after the lymph gets to these bronchopulmonary nodes and then to the superior tracheal bronchial nodes, it'll head up paratracheal nodes. And these nodes have a few different options for where they send their lymph. The lymph can go into the bronchomediastinal trunk alongside the parasternal nodes that we saw, draining the medial quarter of the breast, or it can go up, join the jugular lymph trunk coming down, or it can jump into the thoracic duct. So there's a lot of variation and a lot of choice for these nodes. If it's on the left, it'll go to the left subclavian vein through one of those routes. If it's on the right, it can go to the right subclavian vein, mostly through the right bronchomediastinal trunk or jugular lymphatic trunk there. One thing to note, though, is because we have these carinal or inferior tracheal bronchial nodes, we can actually have lymph from the lower portion of an inferior lung drain up and cross the midline as it spreads. And so spread of infection or spread of tumors from that area can actually cross to the other side of the body. And that's relatively unusual. Here's a nice little diagram, hopefully showing you all the relevant stuff. So I do want you to memorize this diagram, but fortunately it's not too difficult. Just know pulmonary nodes go to hilar nodes, inferior and superior tracheal bronchial nodes, then they can go up peritracheal, inferior deep cervical, supraclavicular, jugular lymph trunk, subclavian vein, or they can jump to the bronchomediastinal trunk and then the subclavian vein directly. I put the heart in here mostly because it's easy. Lymph from the heart has a subepicardial lymph plexus that it kind of coagulates into, and it moves through a single coronary lymph vessel near the atria, and then it can enter the inferior or superior tracheal bronchi, superior or inferior tracheal bronchial nodes to then get into this system. And one thing you need to be cautious of during open heart procedures is not pulling the heart too far away from its base and possibly lacerating or opening up that coronary lymph vessel and winding up with lymph filling the pericardium and causing a cardiac tamponade. All right, question time. Which of the following is a feature of the right lung and only the right lung? Go ahead and pause if you need to, but I can tell you right now, it's C, the horizontal fissure. Next up, go ahead and pause if you need to, and it should be after a motor vehicle collision. I'm not going to bother going in and editing that, just insert the A in as gestalt a way as you possibly can. So, rib fracture on the air side, the left pleural space. Safest place is laterally. So, C or D. And where's the line of pleural reflection laterally? It's between T8 and T10. So C is the correct answer. Same question. Where's the air in his chest? So he has a collapsed lung, so it's hanging out between C, the parietal and visceral pleura. I could have also said costal pleura and visceral pleura, and that would have been correct, but C is correct here. All right, I'll see you guys next time.